Hello, everybody. Welcome to True Confessions. I'm going to give it a couple of minutes and wait for people to sign in. Today's topic is depression. Hello, Elizabeth. Good to see you. I'm going to give it a couple of minutes. If you're here, if you're watching, just say hi in the chat box. Let me know where you're from. I'm going to give it a couple of minutes before I get started. Today's topic is depression. It's an important one, and you're going to learn some things that are very surprising. So stick around. It's going to be very interesting. So if you're signing in, just say hi in the chat box. Let me know where you're from. And while you're doing that, let me just get my slides up. Can you see those slides, Elizabeth? Can you see the slides that says True Confessions Depression? Can you guys let me know if you could see the slides? Let me, you can. Okay, good. Okay. So let me give it just a couple of more minutes. Let a couple more people sign on, and then I'll get started. If you're signing in, just say hi. Let me know you're here. Let me know where you're from. Let you guys get comfortable. Get your cup of tea and put on your fuzzy slippers and get comfortable. It's going to be a good one. We're going to be talking about depression, which I see a lot of, unfortunately. Tabitha Williams is here. Tabitha, it's good to see you. Oh, man. A familiar face. Nice to see you, Tabitha, outside of the office. I'm glad you're here. Everybody else, you know, if you're here, sign in. Let me know where you're from. And I'm gonna get started because I have a lot of information. So I'm gonna get started. So just if you're here, just say hi in the chat box. Okay. And so like I said, today's True Confessions is about depression. Even as a traditional doctor, probably 50% of my visits in a day were probably related to depression, either directly or indirectly. So it's a really important topic. And it's a really important thing to discuss how traditional doctors treat it and how a traditional doctor like myself with a functional medicine background treats it, because it's very different. Our focuses are very different. So, Yvette told you. Okay, Yvette's a doll. She's like my PR person. She spreads the word. All right, so I'm going to get started. And as you guys join in, you know, please just say hi in the chat box. Let me know you're here, because at the end, you know, I like to answer any questions, and I just like to know who's here. So we're talking about depression today. And the first thing I want to do is I want to define exactly what I mean by depression. And I want to use the DSM-5 criteria. DSM-5 is a manual that's used by psychiatrists, and it actually has the definition of what a specific mental illness is. And the reason it's important to define what I mean by depression before I start talking about it is because I want to make sure we're all talking about the same thing. Because you know how some people say, oh God, I'm so depressed. You know, I found out my ex-boyfriend is having a baby. You know what I mean? And it's not really that they're depressed. It's that they're upset or they're sad. But there's a specific criteria to diagnose somebody with clinical depression. So that's why I wanted to go over it here. And the DSM-5 has specific criteria. So the patient has to be experiencing 5 or more symptoms from a list that I'm going to show you during the same 2-week period, and at least one of the symptoms should be either a depressed mood or loss of interest or pleasure. Okay, so they have to have 5 or more symptoms over a 2-week period, and at least one of the symptoms either has to be a depressed mood, okay, a sad mood, or loss of interest or pleasure, because some people are depressed and they don't seem depressed, but they lack, they lost interest in things that used to give them pleasure, like hobbies, they stop socializing, but they're not necessarily sad. So it's important to make that distinction. So the 5, they have to have 5 or more symptoms over a 2-week period. So let me go over the symptoms that they need to have according to DSM. So one is, and they have to have 5 of these. They don't have to have all of them. They have to have 5 of them. So one is obviously a depressed mood most of the day, nearly every day, and it has to be for at least 2 weeks. They have to have diminished interest or pleasure in almost all activities most of the day, nearly every day. So you know how that is, people who are depressed, they don't enjoy the things they used to do. They used to have hobbies, they used to like socializing, they used to go out and exercise, and they just lose interest in all the things that used to bring them pleasure. The third thing is either a significant weight loss when they're not dieting, or weight gain. It could go either way, or a significant decrease or increase in appetite nearly every day. Not like one day here, one day there. They lose their appetite, or their appetite is increased. It has to be consistent over a 2-week period. Slowing down of thoughts, and a reduction of physical movement, observable by others, not just from what the patient says, but from what people around them say. And you'll notice that they're just like almost like catatonic. They're just like really slow. They just sit there. They stare off into space. They barely talk. When they do talk, it's almost in a monotone. It's a very obvious thing that other people notice. They notice that it's actually the medical term for it is psychomotor retardation. And what that means is that their speech is slow, their actions are slow. They're kind of like, almost just, they can't move. So that's something that if you observe that in somebody, the chances are they may have a serious case of depression. Fatigue or loss of energy nearly every day without an explanation. I mean, if somebody has, somebody's sick, somebody's got COVID, over 2 weeks, they're not depressed, they've got COVID. But in somebody who doesn't have another explanation for fatigue or loss of energy nearly every day, and nothing comes up on their blood work, and there's not another explanation, they may be depressed. So that's something to consider in somebody who's got chronic fatigue. The next one is feelings of worthlessness or excessive or inappropriate guilt nearly every day. And not just worthlessness, but also hopelessness, just really low self-esteem, and feeling like the world would be, their family may be better off without them. They can't do anything right. They're not good. They're a good husband. They're not a good wife. They're not a good employee. They're not a good father. They just start having these feelings of worthlessness all of a sudden, and it just it seems exaggerated. That's another feature. Diminished ability to think or concentrate, or being indecisive. One huge thing that happens with depression is that people start to have cognitive impairment. So they, their executive function is impaired. So, they have a hard time focusing. They don't listen. If they read something, they can't, remember it. They're kind of just kind of in a fog. And it's every single day over a prolonged period of time. That could be depression, if there's no other explanation for it. And of course, recurrent thoughts of death, recurrent suicidal ideation without a specific plan or a suicide attempt or a specific plan for committing suicide. That's the hallmark of a really severe depression. So according to the DSM-5, which is what psychiatrists use to diagnose somebody with depression. So again, over a 2-week, at least it has to be over at least a 2-week period. So if somebody has these symptoms for 2 days, they can't be diagnosed with depression. It has to be over a 2-week period at least. And at least one of the symptoms has to be either a depressed mood or loss of interest or pleasure. And they have to have 4 of these other criteria that I just went through. Okay. Now, to receive a diagnosis of depression, these symptoms must cause the individual distress, or it should impair their function in socially, at work, or in other important areas of life, in their relationships. It has to really interfere with their life. For it to really be a diagnosis of depression, and that's tricky because some people are functional. Some people are really functional with depression. So they go to work and everybody thinks they're fine. It's amazing how some people with depression kind of fly under the radar because people around them don't even realize it. And that's a frightening thing because those people fly under the radar and don't get help. And so keep an eye on your neighbor, keep an eye on your coworker, keep an eye on your friends, because some of them may be depressed, but may not be obvious. Now, there's some statistics that are really important. The CDC, according to the CDC, the percentage of adults age 18 and over with regular feelings of depression, recurrent feelings of depression, is 4.7%. That's a lot. That's a lot. The percentage of physician office visits with depression indicated on the medical record, they say it's 9.3%. I can tell you from my experience and from a lot of my colleagues' experience, probably it's a lot higher than this. Probably more, it's more like 30 to 50% of office visits are related to some kind of either depression or anxiety or mental illness. And even that 4.7% quoted by the CDC, I think, is underreported because a lot of people with depression don't go for help. They don't want to go to a doctor. They don't want to see a therapist, and so I think these numbers are actually lower than they truly are, because there's a lot of unreported cases of depression. And the percentage of emergency department visits with depression indicated on the medical record, 11.2%. And again, I think that's a low figure, because I think people with depression may end up in the emergency room with other complaints, not depression. It may be due to depression, but it may be something else. They may have pain, they may have insomnia, they may have something else, but it actually turns out to be depression. So again, these numbers, I think, are under, they're lower than they should be. And in 2019, there were 47,511 suicide deaths. And I'm sure that number has gone up. And again, with COVID, you have to think with COVID, these numbers are definitely higher. These are old statistics. Let me check in with you guys. Everybody here? Everybody sign in? Hey, Ruth. Ruth's here. All right, good to see you guys. All right, let me get back to my slides. So, what predisposes people to depression? Um, there's quite a few things that makes you predisposed to depression. And I'm going to go through these things. One is abuse. Any kind of physical, sexual, or emotional abuse in childhood is going to make you more vulnerable to depression later in life, as a teenager or as an adult. So any kind of childhood abuse is definitely a huge risk factor. Age. Depression can happen at any age, but people who are elderly are at higher risk. And it's usually because of a lack of a support system. It's usually because they're isolated, they live alone. But now with COVID, it's not just the elderly. There's a lot of people who lack social support, who are isolated. So what usually is something that we see more in elderly people, we're seeing in a lot of people of all ages who are experiencing social isolation because of COVID. Certain medications have a side effect that they make you depressed. For example, Accutane, which is used to treat acne, can make you depressed. I've seen that a lot. The pill, I've seen a lot of young women who were put on the pill come in with depression. And the reason that is because synthetic birth control pills suppress your own body's natural estrogen and progesterone. And your natural estrogen and progesterone is very important for mood. So if you're suppressing your own, and this can happen to men as well, if you're suppressing your own natural progesterone and estrogen, you're going to get depressed. And I see that a lot in young women who are on the pill. There are some other medications. The antiviral drug, interferon alpha, can do it. Steroids can do it. They can make you depressed. Lots of medications can increase your risk of depression. It's a longer list, but these are just some of them that I see commonly. The next thing that can predispose you to depression is conflict. Somebody who already has a genetic predisposition to depression, when they have a conflict with family members or friends or at work, that's going to trigger, conflict can trigger depression in somebody who already has that kind of genetic predisposition. So, some people go into conflict and they're cool, it rolls right off of them. It's like they got Vaseline on them. Everything just rolls off of them. Not everybody's like that. Some people have that, don't have that genetic makeup. So, and also they weren't taught resilience as children. So people who have that biological vulnerability, any kind of conflict, dispute, any kind of drama they're gonna get depressed more easily. And this is an obvious one, but definitely death or some kind of a loss. It doesn't necessarily have to be death, but it could be a divorce. It could be somebody moving away, a loved one moving away to another part of the country. But some form of death or loss causes grief and can increase the risk of depression. I mean, let me distinguish depression from grief. Grief is a natural process that we have to go through, to process the loss of someone, either through death or separation or whatever. That's normal. Grief is normal, but it has a time limitation. You go through grief, and although you may never get over the loss of a loved one, eventually you start to get better and you start to function. But grief can trigger depression in someone where the grief symptoms are just prolonged and they just can't get out of it. They can't see a light at the end of the tunnel, and they just can't function. And there's definitely a difference between grief and depression, and it's sometimes hard to tell the difference. And so somebody who's suffered a loss, they can go through that. And like I said, it's not just death or divorce. Somebody who's lost a job, or somebody who's can't do their career. I know a lot of people, their identity is caught up in their career. doctors, nurses, lawyers, or, people who they identify, like their whole life is their career. That's their identity, and they can't do that career anymore. Oh my gosh, they go through a real crisis, and many of them become actually depressed. The next one is hormones and gender. Women are about twice as likely as men to become depressed. No one's sure why, but I am positive it has to do with the hormonal changes that women go through at different times of their life. Men don't have that fluctuation that women get in certain times of life. For example, in pregnancy, after delivery, your hormones kind of, they fluctuate, and that fluctuation in hormones can trigger depression. Men don't go through that because they don't have those fluctuations in hormones. The only time they really do is in andropause, when they go in their 40s and 50s and their testosterone starts to creep down. A lot of men become depressed. But they don't go on birth control pills. That can affect their hormones. They don't give birth. That can make the hormones fluctuate. They don't go through the kind of, they go through a form of menopause, but it's not as pronounced as what women go through during menopause, and women can get depressed in menopause. So and even your monthly period. Your hormones go up and down during your menstrual cycle. Men don't deal with that. So I think the fact that more women have depression has to do with their hormones and the fluctuation of hormones. And I have a story about that will haunt me to this day, and I'll talk about it at the end. But I have a hormones depression story to tell you that it really does haunt me. And I'll talk about that later when we talk about true confessions. Genes. Okay. A family history of depression is going to predispose somebody to depression. There is a genetic component to it. I don't think all the genes have been delineated. It's probably a group of genes, each of them exerting a different effect. But there is a genetic component, as there are for other brain diseases. So again, there is a genetic predisposition. But like with all genetic issues, I always like to say, there is a field called epigenetics, and the purpose of that field is that if you have a gene, just because you have a gene for something doesn't mean that that gene's going to be expressed. And there's a lot of things that can be done to prevent those genes from being expressed. So whenever somebody says, I have the gene for this, or I have the gene for that, with the fields of epigenetics, which is amazing, there's things that can be done to shut those genes off or to prevent them from expressing themselves. So if you do have a family history of depression, please don't assume that you're automatically going to be depressed, or you're going to go down that path, because things can be done, to avert that. Major events. So even good events, starting a new job, graduating, getting married, they can trigger depression. Those are very stressful. Moving, losing your job, getting divorced, retiring. A lot of retirees get depressed because, again, they lose their identity that was associated with their career, and then they some of them don't have anything to do and they're bored. But depression is not a normal response to stressful life events, because look, a lot of people go through these things. We all have gone through this. We all have started a new job. We've all, graduated or got married or whatever, and not everybody gets depressed. Again, there's the reaction, the stress reaction you get to these events, and then there's depression, which is really a prolonged reaction. Other personal problems like social isolation, okay, huge, or being cast out of a family, being cut off from your family or a social group can really increase depression. People who tell me they're the black sheep of the family and they're ostracized by their family often come to me with depression. So social isolation is huge. Let me just check in with you guys and see if you're still awake. Oh, you are, Tabitha? All right. All right, guys, I'm gonna keep going. Yeah, I know. You're right, Ruth. COVID, man. I have no, with COVID this past year, I think I've seen more depression than ever in my 30-year career. Um, I've seen more depression and anxiety, with COVID. So definitely COVID has triggered a lot of depression in the general population. Illness. Serious illnesses can trigger depression. A lot of people, after they have a heart attack, they get depressed. They get clinical depression. There's something about major illness, and it's unclear what the mechanism is, but there's something about major illness that can trigger depression. And sometimes depression can be associated with some illnesses. Like a lot of people with Parkinson's also have depression, but you got to think it's a brain illness. So if there's inflammation in the brain, you may get more than one thing. So that's not, I'm not surprised about that. But interestingly, many people who've had heart attacks end up having depression afterwards. The connection there, well, not so clear. Substance abuse, okay. Nearly 30% of people with substance abuse also have clinical depression. And that kind of makes sense, right? Because it's kind of like they're self-treating their depression, particularly with alcoholism. They're kind of self-treating their depression, but the problem is that the drugs and the alcohol makes them feel better temporarily, but ultimately make the depression worse. So in the short term, that drink makes them feel good and they're happy and loose. And then the next morning, they're even more depressed than when they started. So, dual diagnoses, or people who have the diagnosis of depression and substance abuse, that's tough. That's tough. And definitely a challenge. So that's another one. So how is depression treated in the conventional, in conventional medicine? So if you go to see your primary care doctor or your psychiatrist, and you're diagnosed with depression, basically, they make the diagnosis on those features that I went over. They don't do any blood, there's no blood tests for depression or whatever. And basically they enroll you in CBT, which is cognitive behavioral therapy. So they'll set you up with a therapist, which I think is a great idea. Because when you're dealing with depression, when you're dealing with anything, you really need to learn coping mechanisms, so that you don't do destructive things, when you're feeling sad. So I'm all for cognitive behavioral therapy. And the other thing that they turn to are antidepressants, because a lot of times there are chemical imbalances, low serotonin, low norepinephrine, low GABA, so there are imbalances in the brain chemistry. And so antidepressants help. Problem is, in my experience, and it's been shown in studies, is that a lot of times, traditional treatment doesn't work. People may get a little better, or even significantly better, but not 100% better. If you look at the statistics on antidepressants, it's the rule of threes. So like 1/3 get better and they never have to go on antidepressants again. 1/3 get better, but they have a relapse and have to go on an antidepressant one more time. And then 1/3 can never get off the antidepressants because they don't get better without them. So there's something missing, with traditional treatment, there's something missing. And that's why I like to combine traditional treatment with functional treatment, where there's got to be an underlying cause. There's got to be a root issue, but underneath, it can't just be all like, he lost his job. There has to be something underneath it. And I actually, there's a lot of great colleagues, psychiatrist colleagues of mine that send me patients, and we work together to get the patient better. And that team approach is really, we're really successful. So I'm going to talk about my approach to healing depression. So I'm always in a partnership, and that partnership includes me, the patient, and his or her psychiatrist. We're like, the three of us are like, we get a game plan together, because it's not just therapy and medication that's going to do the trick. And the patient needs to be aware of that, because they're not just going to get better by doing those things. There's some other things that have to be addressed. So I'm going to show you how when somebody has depression and they come to me for help, how I approach it, and how it's different from a traditional approach. And let me check in with you guys. Make sure you're not sleeping. Your dad, Tabitha, he's got depression. Okay. And hopefully some of this some of this information will be helpful. Okay, so let me get back to my slides. So what happens when somebody comes to me with depression? Well, the first thing I do is I have them fill out this really long questionnaire called the Living Matrix. And the reason I do that, it asks so many questions that it helps me identify the risk factors, antecedents, which means, like, are they at risk genetically? Is there a family history of depression? Has there been some kind of an event that triggered their depression? Are they a substance abuser? It helps me identify antecedents and risk factors, but also the root causes at the cellular level, because there's other things behind depression, not just, events, and not just genes. There's other stuff going on in your body that can trigger depression. And I'm going to talk about those a little bit. The other thing I do when someone comes to me with depression is I do very extensive testing, okay? A lot more than you would get from your primary care doctor. I check things like, I check the usual things, your blood counts, your chemistry, your blood sugar, your cholesterol, and, the usual stuff. But I also check nutrients. Okay. Did you know that low vitamin D can make you feel depressed? Okay. Low thyroid, I check hormones. Okay. They're essential for brain health. Did you know that any hormonal imbalance can make you feel depressed? Low thyroid, estrogen dominance, low progesterone, low testosterone can all make you feel depressed. So I check all the hormones. I check the cortisol. I check the stool. Okay. I do stool testing, and GI mapping. GI mapping is a functional medicine test that gives me like this breakdown of all the bacteria you have in your gut. And it's really important information, because there is a relationship between gut bacteria and brain health. Okay, and I'm going to go into that a little bit more. And the other thing I test for is urine organic acids. Urine organic acids is a test that shows me metabolites of a lot of different processes going on in your body. So it tells me if you're low on some vitamins. It tells me if you're processing those vitamins properly. It tells me if you're detoxing properly. It tells me if you have enough good gut bacteria and if they're making the proper metabolites that you need, to have good effects in your body. So these tests plus the Living Matrix gives me tons and tons of information and helps me to focus on what needs to be corrected. So I want to talk about the gut-brain connection, because in reality, the gut is known as our second brain for a reason. Over 95% of our serotonin, the feel-good brain chemical, is made in our gut by our gut bacteria. So if your gut bacteria is imbalanced, not only can you get depression, but you can get severe anxiety. And actually, imbalanced gut bacteria has also been associated with Alzheimer's, autism, Parkinson's, and other brain diseases. So I'm not surprised. A lot of times inflammation in the brain is what is really what the underlying problem is, and we all know that the immune system is also very closely connected with our gut. So there's a very strong connection with our gut and our brain. And when I'm referred a patient from a psychiatrist, one of the things I do is I really focus on their gut health and see if their gut is healthy. Because if it's not, by correcting that, a lot of times their depression or anxiety or whatever they're experiencing gets better. Let me go into that in a little more detail. This is really, really interesting. You guys have heard of fecal transplants. You know, they take feces from somebody and they transplant it into the colon of somebody else. That's been done in humans, mostly in people who have an infection called C. difficile that's resistant to antibiotics. You know, these people are usually, they get, you know, they're put on antibiotics and they get like this horrible colitis and diarrhea that won't go away unless you give them another specific antibiotic. But in some people, it's resistant and it doesn't get better. And so what they do is they take feces from a normal patient and they transplant it into that patient, and that helps to correct their gut flora, the bacteria in their gut, and get rid of the C. difficile, and they get better. However, they've been doing experiments because they've noticed in these fecal transplants, for example, that when they transplant feces from a skinny person to somebody who's obese, not because of that, but you know, because if they have C. difficile, if somebody who has, you know, that infection happens to be obese and gets a fecal transplant from a skinny person, that person who gets the transplant tends to lose weight. I should get one. Where do I sign up for that? But there's a lesson behind that. What that's telling us is that the bacteria, in our gut is responsible for a lot of things, not just making neurotransmitters, but also making hormones. And those hormones include the hormones for hunger and the hormones for feeling full. So lots of information. There's a lot of studies being done with fecal transplants. So studies have been done where fecal transplants have been done between humans with mental illness like depression, anxiety, schizophrenia, autism. So they took the feces from those humans with those mental issues and they put it into mice, normal, healthy mice. These mice who got the fecal transplant from those humans went on to develop these mental illnesses or signs and symptoms of these mental illnesses. And that's huge. What that's telling us is that there's something about the bacteria in the gut of people who have mental illness that's different and imbalanced. And by correcting that, under that root cause, we can help the patient feel better as far as their mood. So our gut bacteria play a crucial role in our brain health. So much so that our gut is considered our second brain. And I'm sure you've heard that before. The brain-gut connection, you know, the gut, our second brain. There's a reason for that. It's true. You know, good bacteria, you always want to have good bacteria in your gut. And the two most, the two ones that we really look for are Bifidobacterium and Lactobacillus. I'm sure you've heard of Lactobacillus. That's the one that everybody, it's in the yogurt and all that. Those bacteria actually produce serotonin and GABA. GABA is a neurotransmitter that chills you out. It kind of makes you feel like you had a Xanax. That's produced by those bacteria. And so how does it affect, how does it go from the gut to the brain? Well, there's a couple of theories. One is that when they make those substances, it gets absorbed into our bloodstream directly, and that goes up to the brain. That's one mechanism. And the other one is that the vagal nerve, our parasympathetic nervous system, I think if you guys watched last week, my stress talk, that if you stimulate your parasympathetic nervous system, that slows your heart rate down and it helps you deal with stress. And there's ways to do that, like meditation and humming So there's ways to do that. So there's another theory. The vagal nerve is actually connects our gut to our brain. And somehow these bacteria produce substances to stimulate the vagal nerve, and that helps us to feel better. It helps us to feel calmer, and it helps our mood. So there, there's a lot of research being done with this, and a lot of different mechanisms being postulated. But the bottom line is that your gut health is crucial to good mental health. And that's something that traditional doctors don't address. They'll give them, send them to therapy and give them a antidepressant, but they don't address their gut health. And that's really, really important. So pathological bacteria, that's the bad bacteria, tend to increase inflammation, okay? And that can affect your brain. An inflamed brain is a depressed brain, okay? And this includes microbes in your mouth. People look at me like I'm nuts when I say when I have them fill out the questionnaire, and I ask everybody if they floss. I'm telling you, I get into everybody's business. And when they don't floss, that just like makes me insane, because I'm like, that bacteria that's in your gums, that can inflame your brain. It's inflaming your gums. That's why you get bleeding gums and gum disease. But that same inflammation can move up to your brain. So even not flossing, can contribute to depression. So it's important to floss. Okay, you got to break that biofilm physically. And poor gut health can also, affect hormones and nutrients that you need for good mood. For example, low vitamin D. If your vitamin D is low, chances are you're going to be tired, you're going to be achy, and you're going to be depressed. Kind of like people who have fibromyalgia. Okay, which I'm going to do a webinar on fibromyalgia, because 90% of people that I treat with fibromyalgia ends up not having fibromyalgia. They have something else going on. So poor gut health just affects everything, including mood. Now, I want to talk a little bit about psychobiotics, okay? What are psychobiotics? So there's a whole field of research now on psychobiotics, and psychobiotics are probiotics with specific strains of bacteria to help improve brain health. And this is a huge area of research right now, because they want to try to use this not only for depression, but things like Alzheimer's, things like autism, things like schizophrenia. This is a huge area of research. So again, this is just more evidence that good gut health is really crucial to good brain health. So remember that term psychobiotics. You're going to be hearing a lot more about that in the future. So my treatment is holistic. Okay, it's not just, dealing with one thing. It's addressing, the psychological root causes. I always talk to people about abuse. I talk to people about their stressors and how they're managing stress. But I also work on healing the gut and balancing the hormones and correcting nutritional imbalances and teaching mindfulness and resilience and stress management techniques. So I kind of, my treatment's really, really, really holistic. And when I work in conjunction with a psychiatrist, I'm telling you, we get the most amazing results. So let me just check in with you guys. Everybody good? Okay. Oh, Tabitha. Tabitha, you should come do a functional medicine evaluation. We should, you know what? We should have you see Sophia when you're in the office. You should talk to Sophia. Get you a functional medicine evaluation. Okay, so true confessions. I always have to give an example from my own life. So, it's no secret. I've told many videos that growing up, I had horrible gut health. I mean, I had antibiotics multiple times, numerous times. I ate a lot of processed foods. So I was perfect setup for depression. And there have been times in my life that I have been depressed, not bad enough to seek out medical attention, but at times in my adolescence and in college that I've been depressed, but not long term, and it kind of resolved on its own. But I would have to say probably I didn't know it at the time, and I wasn't diagnosed with it at the time. I probably had a little bit of postpartum depression, the fluctuations in the hormones. And at the time that I had my children, I had never addressed my gut issues. So, I had a little bit of postpartum depressions probably, which I have been treated for. But now, now that, I have addressed, I have done functional medicine on myself, mostly to cure my own, health issues like my migraines and my menopausal weight issues. My mood is actually pretty good. And I think that's because I really, really healed my gut. But the story that I was alluding to earlier that really haunts me to this day is a story that was told to me by one of my teachers, one of my professors, who was actually in one of my hormone classes, one of the classes where I was learning about hormones. And he was an ER doc. And a woman came in a suit. She was really dressed really nice. I guess she had just come from work, and she had just had a baby, I don't know, like 2 weeks before. And she came in and very calmly said that she was suicidal and that she was having thoughts of killing her baby. And so this genius, fast-thinking ER doctor gave her, I don't think you can give it IV. I think you have to give it by a shot, but he gave her progesterone because what happens with postpartum depression is that there's a hormonal imbalance. And so he gave her progesterone in the emergency room, and they observed her. And within an hour, she snapped out of it. Like, she felt like, oh my God, like a cloud had lifted, and it was a hormonal thing. And so that's so frightening with women, because, our hormones sometimes are all over the place. And traditional doctors don't recognize that. They don't make that connection. If it hadn't been this particular ER doctor, she would have been admitted to psych, and she would have been started on antidepressants, and they would not have addressed her hormones or her gut health or any of that. It could have gone totally different, and she probably wouldn't have gotten better. But this quick thinking ER doctor gave this woman the correct thing, and it saved her life and her baby's life. And she was fine after that. So, doctors have to think, the moral of the story is doctors have to think outside the box. We don't know everything. We don't know everything. There's a lot that's unknown, and there's an art and a science to medicine, and everything I'm talking to you about is science-based, but there's a little bit of an art there too. You got to really talk to people and get to know what's going on in their lives. And so if you have depression, and you're not getting better with traditional treatment, if you're on an antidepressant, if you go to therapy and you're just not getting better, and you want to talk to me about what I can do to help you, just go to my website, Vitality Medicine of New York. There is a place where you can make an appointment for a free phone call to discuss your issue and see if we're able to help you. Okay, because help is available. And I want to mention one other resource. There's an amazing psychiatrist that I collaborate with a lot. He's brilliant. He's been written up in the Washington Post. He thinks outside the box. People come from all over the world to see him because he, in thinking outside the box, has things up his sleeve where he is able to bring people out of a suicidal episode like that. I mean, he has a lot of high profile clients that I'm not at liberty to name, but people, actors, politicians, people have come to him in acute suicide, having acute suicidal ideation, and he's been able to get them out of it like in a day, using a variety of techniques. He really thinks outside the box. So the reason, I want to bring him up is that he's a wonderful resource. His name is Dr. Hassan Asif, and he runs the Brain Wellness Center of New York. You can go to their website. And if you're somebody who's, I know there's a lot of people who, they've gone from, psychiatrist to psychiatrist, not just for depression. He's helped people with autism, people who've been nonverbal. He's gotten them, verbal and functional, and he has worked miracles. And, he and I collaborate a lot, and we get great results, but he's amazing. Look for his Washington Post article, which describes how he has developed his proprietary protocols and a little bit about his background. But if you're somebody who's been struggling with depression or have a family member, or not only depression, but mental illness with autism, and you just, feel like there's nowhere to turn, that nobody can help you, he's your man. He is brilliant. And I'm actually going to be doing an interview with him on one of my Facebook Lives, because he's just a fountain of information and he's a wonderful resource. So does anybody have any questions? Does anybody have any questions on anything that I presented in my slides? Tabitha, if you go to Vitality Medicine New York website, and you go to schedule a free call, you can schedule a call with Sophia, and she can get you all the information about doing a functional medicine evaluation. And anybody else who's interested, not just for depression, but for, just in general, if you want to do a functional medicine evaluation, she's the person to talk to. Does anybody have any questions? Okay, well, thank you so much for joining me for True Confessions. Not sure what next week's topic is going to be. I might have to surprise you guys. But I'll let you know. I'll post it on Facebook and Instagram, because I'm kind of, there's a couple of topics that I'm going back and forth on, and so I'll let you guys know what next week's about. But thank you for watching. Thank you for tuning in. It was good to see you, Tabitha. And thank you for tuning in, guys. And I'll be back next Wednesday. I do this every Wednesday at 7 p.m. I'll let you know what next week's topic is. And thank you for joining me, and have the great rest of the week and a wonderful weekend. And I'll see you next week. Good night.